I think the work that is being done by AAKP is so critical to patients all around the country. Their ability to advocate on our behalf ensures that everybody understands the impact of kidney disease and what they can do to help us.
Now everybody is fully understanding that to achieve a better quality of life, you really need to listen and take into consideration what the patient views as a better quality of life for them.
I always have fun at an AAKP event. How could you not have fun? You're with people who understand completely what you and your family are going through. So it's not just for patients, AAKP. AAKP should be for the family of patients, because when a patient has kidney disease, the family has kidney disease.
Belonging to an independent advocacy organization like AAKP gives me the confidence that I can represent them and people living with kidney disease to represent them honestly.
Our objective over the coming decade is to reach people around the globe and not just limited to the United States, because kidney disease is a universal disease.
They encourage patients to be the voice for their care and treatment. And I don't see that as much in other organizations. And I feel like that is so necessary for patients to feel like they have a voice and they can make change in regards to their care and treatment.
I think the AAKP, by being a patient-oriented group, impacts not only the medical devices, but pharmaceuticals and pretty much anything that's to do with the patients, because those companies will respond more to a patient than they will to a doctor, I think.
It's important to be a patient advocate because to whom much is given, much is required. I was given this gift of life back in 2008 by my donor, Leanne, rest in peace. She was a deceased donor. So now if I can use my voice and use my platform and influence to impact lives, and my favorite word, why not? And why not become an organ and tissue donor today?
We spend a lot of time here, particularly in DC, in the nation's capital, talking with staff, with the legislators, and trying to help them understand exactly what the patient perspective is on anything that's kidney or renal related. It's a great honor to be able to do it. Our numbers are growing, and part of our strategy is for them to understand that we will come and visit and talk with them, and we represent the patient voice, and we want that to be heard, and that's how we do it.
People around the world who are sick and suffering with kidney disease need a voice of optimism, they need the tactics, and they need the reinforcement from fellow patients here in the U.S. to do what they do and demand a change in the status quo. And we fully intend to arm patients around the world with the tools they need to be more vocal with their governments, regardless of the ideology of their government, and to demand solutions and to defend private sector companies and investors who are willing to get into this space and deliver more innovation for patients.
AAKP opens the door so that it broadens the whole horizon. You're one person. When you belong to AAKP, you suddenly become a tribe.
Welcome to today's Healthline webinar, the latest in our COVID-19 series, Telemedicine Utilization in the COVID-19 Era, What Patients Should Know. AAKP is the nation's largest independent kidney patient organization, and we are vigorous advocates for the right of patient consumers to choose the therapies that align best to their personal aspirations and life goals, including kidney transplants and home dialysis. AAKP's Healthline webinar program falls under our Center for Patient Research and Education. We believe patient and caregiver education is an integral part of treatment and protection of patient lives, and we work to ensure that patients remain at the center of all kidney research and policy that impacts their lives. This includes federal policies and private sector innovations that impact healthcare services, assistance programs, and access to new products and services. This is especially true during national emergencies such as the coronavirus pandemic, because kidney patients are considered among the most vulnerable populations. Before we get started, we want to thank our webinar sponsor, CareDX, who would like to share a brief message on CareDX's response to COVID-19 to help support the transplant patient community.
As the COVID pandemic was growing, we heard from our clinicians and patients that they were skipping appointments and blood draws that are necessary to maintain the health of their allografts. We came together and built out RemoTrack over a weekend.
Go to caredx.com/RemoTrack to sign up, and we will follow up with your clinicians directly to line up with your normal testing schedule. CareDX will fully cover the cost of your home mobile phlebotomy and ensures that you will have no additional out-of-pocket costs than your usual routine tests.
Hello, Transplant World. Edward Mr. Wynot Drake is here. Hope you all are enjoying your Donate Life Month and staying safe. I came here to share some exciting news. Our partners in transplant care, CareDX, who created the LMF and AlloSure testing, has just come out with a at-home blood draw service, which I'm really excited about, called RemoTrack. If you all are like me and have to travel far distances and wait in long lines to get your blood drawn often, this is no longer the case thanks to CareDX.
At this time, I'd like to introduce AAKP's president, Richard Knight. Richard is a former in-center hemodialysis patient who received his kidney transplant over 14 years ago. Richard?
Thank you, Erin. And I thank everyone who's joined this call today. In joining us on this call, you are showing concern for kidney patients and the threat that COVID-19 represents. We thank our partner, Quality Insights Renal Network 5. AAKP has a long history with Network 5. Myself and Paul Conway have served on their board of directors, and I've been a member of the network's Patient Advisory Committee for over 11 years. AAKP, we've had 50 years serving as the independent voice of patients, and we take our role in educating patients and providing policy leaders insights into patients' concerns very seriously. The COVID-19 is a serious threat to all Americans, especially those of us with underlying health conditions who are immunosuppressed, like kidney patients, including myself. COVID-19 is also accelerating the transition to telemedicine, and AAKP has long supported an increase in telemedicine because it offers patients more choice. And the team, no, I should say my friends who are presenting today, will speak to the many aspects of telemedicine. But first, I ask a favor of all of you who are listening and watching. We need for you to stay connected to AAKP and share your involvement in our online efforts. Because although our reach is growing, we believe we need to educate more patients on how serious this virus is and the threat that they face from it. I will now ask my fellow transplant recipient and AAKP Chair of Policy and Global Affairs, Paul Conway, to talk about our survey research that led in part to today's program. Paul?
Thank you very much, Richard. And for all those who are listening, the AAKP Center for Patient Engagement and Research does a very aggressive effort to reach out to the patient population, including the tens of thousands who have listened to these webinars that we've done on COVID-19 over the past 6 weeks, to gain your insights and your perspectives so that we can offer federal agencies, including the NIH, FDA, CDC, CMS, the Department of Defense, and the VA, with real-time patient insights on policy issues that are impacting them. We also use our surveys to inform decisions at the White House and in Congress. We are nonprofit, but we are bipartisan in our relationships, and we are nonpartisan in how we operate. So we offer patient insights for any policymaker who's working on issues of concern for the patient community. When COVID-19 first entered the public arena, we went out to our patients and we asked how many patients were actually concerned about the virus and their impact, and how many patients were hearing back from their doctors. As you can see from this flash survey result at the top, 78% of the patients that we surveyed indicate that they thought that the coronavirus is a threat to them. And that is actually what ended up driving many of these webinars and many of our interactions with Congress and with the White House, make certain that the patient voice was represented on key issues. As Richard mentioned, we encourage you to stay engaged with us because your insights are delivered in live time to many of the policymakers that are making decisions not only on coronavirus, but on many of the other issues that are impacting your lives. So stay tuned. You'll have future opportunities and invitations to participate in our survey research. Thank you, Richard. Back over to you.
Thank you so much, Paul. We have a busy program today, so let's go ahead and get started. Our first speaker today is Dr. Amber Paulus. Dr. Paulus is a health services researcher and registered nurse, currently working as a clinical data analyst and patient engagement specialist for Quality Insights. Her research focuses on examining payment models supporting value-based purchasing programs, quality of care measures, and how nurse-led interventions influence patient outcomes. Amber, I'll turn things over to you, and you should be able to advance with your mouse or keyboard.
Thanks, Erin. I want to take the opportunity to thank AAKP for partnering with us on this webinar. With the growing concern of COVID-19 and its potential impact on kidney patients, CMS has asked the ESRD networks across the country to educate patients about the opportunities that telemedicine offers during this unique time in our country. So with today's webinar, we hope to be able to go over these few objectives. First, we're going to discuss the expansion of telemedicine and what the waivers that CMS has implemented has made available to patients, define what telemedicine means, and we'll identify what technologies are available and how to use them. And then my colleagues on the call will go through important topics to cover with the dialysis clinic during telemedicine visits, including home dialysis perspective, what that's like in the home in-center hemodialysis facilities and for transplant patients. And then finally, we'll wrap things up with two patients sharing their experiences with telemedicine throughout the COVID-19 pandemic. So for some background, under President Trump's leadership, CMS has broadened access to Medicare telehealth services. And so actually a year ago in January, the services were broadened in the sense that patients were allowed to hold meetings in their home. However, these waivers have increased access to patients to allow them to have more opportunities to hold care meetings with their patients from their own home environment instead of having to go into the clinic. So beneficiaries or patients are now able to receive a wider range of services from their doctors without having traveled to an actual healthcare facility. These policy changes have built on regulatory flexibilities granted under this emergency declaration. So after the COVID-19 era potentially passes, things may revert back to the way they were, but our hope is that the infrastructure will have developed in such a way that this will continue to be an opportunity for patients, but that remains to be seen as things continue to evolve. This expanding benefit is on a temporary and emergency basis under the 1135 waiver that is the Coronavirus Preparedness and Response Supplemental Appropriations, or also known as the CARES Act. So what did this waiver do? Under this new waiver, Medicare can pay for office, hospital, and other visits furnished via telehealth across the country. And this started at the beginning of March of this year. Medicare beneficiaries or patients are now able to receive a set of services through telehealth, and these include common office visits, mental health counseling, and preventative health screenings. These can be conducted in the patient's home. It's also ensuring that patients who potentially, kidney patients specifically, who may be higher risk for COVID-19, are able to visit with their doctor from their own home without having to go into a hospital or a doctor's office and put themselves or others at risk. So specifically, what does this mean for patients? There's still required monthly connections to be made between a patient and their care team, including a visit between the patient and their physician, that the physician would write a comprehensive physician note on the patient, that's in order to allow them to bill. There still needs to be blood work done, and there still needs to be some form of nursing visits with the patient. Now, the application of this, so the waivers exist, and CMS has made these waivers available to allow flexibility for how care providers interact with their patients. But how that is applied is really up to the managing nephrologist or the dialysis facility who's responsible for the patient's care. So they may implement the flexibilities offered by the federal government at their own discretion based on their unique perspective of their patient population and the touch points needed to manage the care of the patients. Some of those providers may choose to implement the waivers to their fullest extent, meaning that they'll hold the visits whenever possible via telemedicine from the patient's home. And others may require the patient to come to the clinic to be seen for face-to-face meetings or blood work, and that might be specific for home patients who are mostly in their own home environment to begin with. But the application of how these waivers are applied will vary based on provider. We just wanted to make sure that that was clear. Okay, so to define a little bit about telehealth or telemedicine and what I mean by that, these terms are general terms that refer to the exchange of medical information from one site to another through an electronic communication with the ultimate goal of improving a patient's health. This is considered innovative. It uses a technology in the healthcare setting, and this has been on the rise. Even prior to COVID-19, there were places that were already using telehealth and telemedicine, and one of our speakers today may touch on that a little bit more specifically. But it has been increasing over time in ways that we needed to overcome geographic barriers and get patients the care they needed when they needed it, and using telehealth was one mechanism to do that. But there really is a true need to continue to increase the use of telemedicine in this COVID-19 era. There's now an urgency to expand its use. So it not just be, we were using it previously due to geographic barriers or patients having to drive long distances to see their care team. Now it's really about safety. So those who need routine care may be vulnerable to COVID-19 because we don't know everything about this disease at current day, or how the virus spreads and all of the ways that it might do that. It's novel, it's new. So even those with mild symptoms are given the opportunity to stay in their homes to not spread the virus to other folks, but also to prevent them from ever contracting it in the first place. So this limits the community spread of the virus, as well as limits exposure to patients or even the staff members who's caring for them, and hopefully slow the viral spread. There's also other advantages outside of just COVID-19. It can make care more convenient and definitely more accessible. It can save on travel for the patients if you're driving long distances to meet with your care providers. It also could increase the frequency and interactions between physicians and their patients and their care team in general by being more accessible in a remote fashion. It also enhances the potential for care coordination. So now that things can be remote or via electronics technology, multiple care providers could be on one call with a patient or one telemedicine session with a patient at a time. And it's also slightly more interactive than a telephone call to be able to see someone visually and see everything that's going on with the patient, even if they're not physically in front of you. So the three services that the waiver is now allowing are Medicare telehealth visits. This is a visit with a provider that uses telecommunication systems between a provider and a patient. A virtual check-in. This is a brief. So with the one on the left, the first one, Medicare telehealth visit, is more comprehensive. A virtual check-in is just that. It's just brief, maybe 5 to 10 minutes to check in with a practitioner via telephone or telecommunication device to decide whether you need to be seen in person. So if there was a concern, maybe a vascular access concern, if you noticed something going on that didn't appear to be normal, you could do a brief check-in to say, hey, do you think I need to come in to be seen? Or do we monitor from home? And maybe it's multiple iterations of virtual check-ins that are brief to monitor the patient from their own home. It also can be a recorded video, or images can be sent from the patient to their established care team in order to try and coordinate care from the patient's home environment. And then finally, an e-visit. So this is communication between a patient and the provider through an online patient portal. And a lot of patients are already using the online patient portal to track labs and things like that, but request medication refills, but that's the purpose of the e-visit, to be able to do all of those things through an actual patient portal. So the last thing here is to talk about, there's multiple vendors. This isn't to advocate for one or the other, but just to say these are all of those that are out there, and there may actually even be more. This is not an all-inclusive list. For video conferencing, direct-to-consumer. Direct-to-consumer means that these are ways to access a care team through this format. It wouldn't be your own personal care team, but it's something, it would be like going to an urgent care via telemedicine. And then provider access software is really speaking specifically about provider access for the physicians. But these are the options at the top left, video conferencing mechanisms that a patient might see their physician using to communicate with them from their own home. So with that, I turn it back over to Erin.
Thank you so much, Dr. Paulus. Our next speaker is Dr. Rebecca Schmidt. Dr. Schmidt is a nephrologist who brings 27 years of clinical experience with patients across the continuum of chronic kidney disease from early to late disease, including those with dialysis-dependent end-stage kidney disease. As a physician of record for some 90 in-center and 20 home dialysis patients at 5 outpatient dialysis facilities, she has traveled extensively across North Central West Virginia to see patients face-to-face for the past 20 years, in addition to using telemedicine to reach those most distant. Recent events have prompted increased use of telemedicine for both in-center and home dialysis patients, and many non-dialysis patients with CKD are being seen by telemedicine video visits. Dr. Schmidt serves on the board of directors for ESRD Network 5 and the medical advisory board for the American Association of Kidney Patients. Dr. Schmidt, thank you for joining us today, and please let me know when you are ready to advance, for me to advance your slides.
Well, good afternoon, and thank you very much, Erin, and thank you very much to the organizers for including me in this presentation, and mostly thank you to the patients who are listening. I hope this will be helpful to you. And you know, as Erin and Amber have said, this is kind of you know, this is really unprecedented times we're in. Although, you know, telemedicine has actually been used for quite a few years in a lot of patient settings. I have been doing it off and on for quite a few years, more than I'd like to count. But up until recently, we really didn't have a mechanism to do this in our dialysis units and for our dialysis patients. So, you know, the use has really exploded with these waivers, allowing us to take care of not just the home patients, but the in-center patients by telemedicine. And there's a variety of ways this can be done, and scenarios that I'm going to talk to you because, you know, what each patient's needs are different, and everyone's situation geographically is different. And some of the telehealth, you know, decisions to use telehealth or telemedicine are going to be dependent on the location of a patient's home, the location of the doctor, the location of the unit, and also how stable and perhaps complex a given patient's clinical status is. But right now, of course, we're really encouraging still, even though a lot of states are opening up, you know, we're not doing that yet in the dialysis units, but we're really encouraging that face-to-face visits are minimized, particularly to patients that are at risk, which are patients on dialysis and transplant patients. So, you know, being able to see patients via we call them the video visits, has been really not just a lifesaver, to lack of a better phrase, I guess, but clinically, but it's kind of fun too, because as Amber was saying, you know, sometimes we are able to get more care partners on the call. And I don't know if whoever might remember that show on TV, Hollywood Squares. I might be really dating myself here, but the Hollywood Squares, where you have all the faces on the TV. Well, it's kind of like that sometimes when we've got everybody together on the telemedicine call with our patient. So you can go to the next slide, Erin, please. Next slide. And this is just kind of a summary statement of all the different scenarios that we can use, or that can be achieved with telemedicine. And it's not just about distance, although that's pretty much my life, because my patients, most of them live distant to where I live. And but telemedicine, as I think Dr. Lee will probably tell you later, is also, very useful for settings where it's either just clinically not appropriate to have a face-to-face visit, for instance, patients being at risk for COVID here, but also, there's a lot of scenarios where, for instance, in the dialysis unit, there can be situations where the patients, home patients, really want to come in fewer times than maybe we think they really could come in. It's not like the patients don't have anything better to do than come to the dialysis unit, but we do need to have a nursing visit usually, and we do need to, for home patients, we do need to take a look at their access every once in a while, perhaps every couple months. And also patients do need labs. And I think some patients are able to draw their own labs at home, particularly the home hemodialysis patients, but many patients do come to the Center for Labs. And what telemedicine has allowed us to do is to have these visits be, it's more convenient, can be at the convenience of the patient. It's not just on the day that the doctor can be there that the patient has to be there too. So it offers a lot of flexibility and variability in the way we are able to provide care, and having more people can be involved in even one visit, with the Hollywood Squares type of picture than in the past. You can proceed to the next slide, Erin. So one of the situations, and this is very common in my state, West Virginia, is where the patient lives distant to the dialysis unit, a couple hours or even an hour or whatever, or, and the physician, and also that unit is, and the patient lives distant to the physician's office. So, the patient, what might be, happen is that the physician may drive to the unit, and and this happens in our situations. I will drive to one of my dialysis units, and the team is all there, and we have the patient on the telemedicine screen. The patient is at home, and we conduct the visit in that manner. Next slide, please. Another scenario would be where the patient lives close to the dialysis unit and is able to come in, where the nephrologist lives distant to the dialysis unit. So the patient comes to the dialysis unit, and the physician is on the screen in their office or wherever elsewhere. So this is one scenario that can be done. This is not the only scenario, although we had some conversation the other day about whether or not this was something that was the only available to patients, and I would say that would be a no. I think both for Fresenius and DaVita, and I've been in contact with both of the companies to ask them what their stance is, and basically, they're doing this in a variety of ways as well. Whether the patient meets meets the team face to face, and then that group meets the doctor, or vice versa, where the doctor is at the unit and the team, including the doctor, meets the patient when the patient is at home. So I think there's a lot of ways this can be done, and a lot of it will depend on what's available and what makes sense for that patient in that setting. And I would encourage anybody that is not clear about what the settings that are available for them, I would encourage them to inquire, because there's a lot of ways this can be done. This is not a one-size-fits-all type of modality, and it's not a one-size-fits-all situation. Next slide, please, Erin. Now, I think I probably really discussed this, but this is another situation, and we do this quite often, where the patient is at home with their family or themselves, and they're connected to us, and we have, instead of a Hollywood Squares with everything, well, we do have, it is the Hollywood Squares, but the physician and the dialysis team are separate. So, the physician is in their office, and the patient can be at home. with their family or in the dialysis unit or vice versa. And I think there's a typo in this slide here on the one side, but basically you can have the situation where you can have all of us at different places kind of zoom in for the visit. And that we do that quite often. Next slide, please. And this is just a picture of what I've been doing lately. Is I'm and this is a picture of myself in my office with the two screens, and that is not a patient, it's my nurse getting ready to present a patient. So, you know, I have the screen there, and they can see me on their big screen. I can see them, and on my other screen, I have their medical record there, so that I can speak to them intelligently about what is their specific issues are, and have their medicines up at, you know, available for me to look at. And that way, you know, I'm seeing people from in our state, several different areas of the state, and it's very helpful. It's very helpful to me as a physician that travels, because sometimes when I go to the dialysis unit, the patient is ill or can't make it, or maybe they're in the hospital, and this makes it possible for us to see each other a different way if we cannot connect in person for whatever reason. So, you know, I think you know, to say that, you know, telemedicine has been around for a long time, but it's evolving. I guess I would say it's more like exploding, which I think is great. And it may be ideal for some people and some patients, and it may be less than ideal for some patients, and it may depend on the scenario. It may depend on the setting of the geographic setting of both the patient and the unit. It may depend on the preferences of the unit, the local unit, or the physician. But I would encourage anybody that isn't you know, that is not happy with their scenario to inquire, because it's likely can be done a different way. And it really needs to be centered around what is best for the patient and what is convenient for the patient. And that's really how we try to do that here in West Virginia in our group. So that's all I have. And I thank you again for allowing me to talk about what I find to be a very exciting and very helpful to me, because I am one of those people that worries if I don't see everybody when I'm supposed to be able to see them. So it's very helpful to me, and the patients have been very excited about it and have thought it was fun. And you know, it's unfortunately the resolution on the TV screens is so good that you really can't go without your combing your hair or anything like that, because the resolution is very good and you can see everything that you need to see. So with that, I'll stop, and thank you very much.
Thank you so much, Dr. Schmidt. Our next speaker is Dr. Janice Lee. Dr. Lee is a professor of medicine at Emory University and is board certified in nephrology and hypertension. She earned her medical degree at the University of Texas Medical Branch at Galveston and completed her residency in internal medicine and a nephrology fellowship at Emory University affiliated hospitals. She also received a Master's of Science degree in clinical research from Emory School of Public Health. Dr. Lee is currently a professor of medicine at Emory University, where she has practiced for over 20 years and is the clinical director of nephrology and the chief medical director of Emory Dialysis, which serves over 800 patients, including 150 on home dialysis. Dr. Lee's research and clinical experience are in hypertension, chronic kidney disease, kidney health disparities, and dialysis. She is nationally renowned expert in hypertension, designated a clinical specialist in hypertension by the American Society of Hypertension. Dr. Lee also is a designated master clinician by Emory's School of Medicine and serves as the director of telenephrology at Emory since 2017. She serves on the board of directors for the American Association of Kidney Patients and has been named one of Atlanta's top doctors for the past 10 years.
Well, thank you, Erin, for that introduction, and I'm just going to add to the excellent presentations that have already taken place and laid the groundwork for telemedicine, and I'm going to specifically focus on in-center dialysis rounds. So again, you've already heard the details about the CMS waiver for telehealth. Basically, this used to just be available for patients in rural areas and for home dialysis. But this was really unprecedented for CMS to now allow us to be able to see patients in center rounds. Next slide. This slide is showing the legislation, and just so you know the time course of when it was allowed for home patients to actually receive care by telehealth that Dr. Smith has talked about. So that act was passed in 2018, effective January 2019. And it allowed the patients to be seen in their home instead of having to go to a rural clinic or a local clinic to be seen that way by the physicians. This was allowed for 2 out of 3 visits, so the patient could be seen 2 times in a row each month, and then the 3rd month would have to physically come in. And so, as you've already heard, for home dialysis now, they're allowing all 3 of the visits to be monthly visits by telehealth. So as long as this pandemic goes on, each visit can be allowed by telemedicine. You don't have to have one of the out of 3 to be in person. And then the major thing that I'm focusing on today is the allowance in in-center rounds. When this first came out, it was mentioned, you know, we have 4 visits that the nephrologists have to make on the patients in center, usually once a week. When this originally came out, they said, well, 1 visit still needs to be face-to-face. And then 3 visits could be by telemedicine, but that quickly changed to all 4 visits could be conducted by telemedicine. As you've already heard, there's different forms of telehealth and communication, including phone visits. Phone visits are allowed for other clinic visits outside of dialysis, i.e. your primary care physician. CMS is allowing or has waivers for patients to be evaluated through phone visits and allow the physicians to get reimbursed for that service. However, the big distinction is for in-center dialysis rounds, the phone visits are not allowed. Only the telehealth visits that involve video conferencing capabilities where the physician can actually see the patient. Next slide. This information is just something that we have to document when we see the patients by telemedicine. And this is for the primary care docs in their offices if they're seeing patients at home. This is also for in-center dialysis and for home dialysis, that we just have to actually state in our note that we create for the visit that the patient was seen during the COVID pandemic. So to justify why we're doing telemedicine, and that we discussed with the patient why we're doing this. And they of course have to give their permission. If they do not want to be seen by a tele video conferencing, they have the right to not do that. We also have to state that the sessions are not being recorded. Obviously, we want to make sure that there's patient privacy guarantees in this process. And that if there's anything that comes up later, that we will be available to follow up as needed after the visit. Next slide. So you've already heard the designated waiver for the tele video conferencing. Here I just mentioned that there was also a statement in these waivers to allow use of various platforms that may in the past have not been considered totally HIPAA compliant, that they're not going to penalize physicians or providers to use these various platforms. Of course, they have to use some measures to ensure some security, but there's been different discussions about different platforms and how secure, etc. But they were allowing you to use whatever platform that you could work out and deem the best platform for your practice. For Emory, we have been using a couple of different platforms, including Zoom, FaceTime, and even Doximity and GoToMeetings to actually see the patients and actually to conduct team rounds, which I'll mention on upcoming slides. Next slide. So what does a telehealth visit in the in-center dialysis look like? Well, we have the nurse go around with a cart that has an iPad, and this is for our program, but it could be different for others. And we use FaceTime or Zoom. And so what this allows is that we can see and talk to the patient like we always do when we go chair side. And the nurse is there to help maneuver the iPad to where we can see the patient appropriately, and also to move it around for us to do a physical exam, i.e. Check the legs for swelling like most nephrologists do when they round in center. You can have a look at their access. You can visualize any particular abnormalities that the patient may have, such as a skin rash, etc. Now, I'm going to mention this. This is also a capability because some of the patients may be inquiring, because usually the nurse listens to the heart and lungs. The physicians may not always do that every visit, but they usually do it periodically. I'm going to talk in a minute about how that can be accomplished if needed, but it's not a requirement for the actual weekly visits. We can look at the dialysis machine. I have a picture of that coming up. So I have the nurse direct the camera to the dialysis machine. So really, I'm doing everything that I would do except laying hands on the patient by telemedicine. And I can actually have the nurse lay the hands on the patient to whatever area I need to examine. She can check the abdomen if the patient is complaining of pain. She can palpate or push on the abdomen to determine if there's any localized area that is concerning or tender. So with the dialysis machine, we can look at the blood pressures, the fluid removal, blood flow, etc. So we can identify, just as if we were there in person, if there's any particular problems or impending problems, and can adjust fluid removal rates as needed. We also use this platform to conduct our team rounds. As you all may be familiar, at least once a month, the physician rounds with the nurse, with the social worker, with the dietitian. Now, at our clinics, because of COVID, we have allowed certain ancillary staff, meaning the patient, the staff that is not clinically taking care of the patients, the nurses or the technicians, we've allowed them to work from home. And so because of we want to reduce exposure to everyone, including the staff and the patients. And so they are actually calling in we can arrange a go-to meeting for the group or a Zoom meeting so that they can participate in our monthly sort of team rounds that we usually have. So the patients are still benefiting and getting the same service that they were getting before the COVID pandemic. Another neat thing I would just mention for home dialysis rounds, we're also doing it as Dr. Smith described. And with the Zoom platform, you can actually share your screen. And so I can pull up the patient's chart and review their labs with them. And they really like that. They really get excited about that. So we're really doing everything that we would be doing if we were there in person. Next slide. Next slide. Okay, this is a slide that just shows the iPad, the dialysis machine. This is a home dialysis machine that's depicted in this diagram. And then the electronic stethoscope. Now, again, the electronic stethoscope is not a required thing, but it's actually very beneficial to be able to have this in the clinic. If you could go to the next slide. I think well, I'll get to that in a minute. Let me just show you this. This is the dialysis machine that you all are familiar with, the screen that we're looking at. And so we can be, looking at the patient, looking at the screen, determining if the blood pressure is too low, if we need to adjust the UF goal, etc. So again, everything that we would be doing as if we were physically there. Next slide. So the electronic stethoscope, I think, is really, really neat. And what this allows is that the nurse can actually place the stethoscope on the patient, and you just have to have an app on the iPad, and then the physician has to have the app on their phone. And so while the nurse is placing the stethoscope on the patient, the sounds are recorded and can be transmitted electronically through this web-based application. And so the physician can actually hear the heart sounds and the lung sounds. There's one particular type of electronic stethoscope, the echo stethoscope, where it allows you to actually see a tracing of the heart. And so we're just now implementing this in our dialysis units, but very excited that it's something that we can do to even improve the care and the evaluation of the patient even more than what we're doing currently. Next slide. This is just a cartoon of the technology for the echo stethoscope. So you have the patient on the sitting in the chair, and the nurse holding the iPad. This is a more of a diagram of someone who's dressed in full attire to prevent COVID, etc. But he's able to put the stethoscope on the patient, and then the physician can be to the right, can be anywhere at home, at his office, at another dialysis unit, etc., and can actually hear the stethoscope sounds and see the tracings on his either computer or phone. Next slide. So why are we doing this? Well, CMS, of course, has allowed this, and for several reasons. I'm sure all of you heard that there was a shortage of personal protective equipment when everything started, and so this was a way to limit the use of personal or PPE for physicians and for other staff members in the dialysis unit to be able to see the patient from home. I think the major issues are 2 and 3. reduce medical staff exposure, so our ancillary staff, etc., would not be exposed to any possible disease, and mainly the patients. Really, you know, the physicians are still working, they're still going to other places, they're going to the hospitals and having potential exposures. And so it was felt that it was wise to discourage the nephrologist from actually physically going in the unit to minimize any unnecessary exposure to the patients. To maximize the utilization of the provider workforce, again, you know, the physicians, you know, there was a major concern in other places that have had physicians and providers get sick and not be able to actually physically come in to the hospital or office, but if they were under quarantine, etc., could still see patients from home. And so that was one of the other drivers of this capability. What I really think has really come that we are really enjoying is the group rounds, cyber rounds with the dietitians, social workers. We can even bring in family members as needed to participate in the rounds. And I think going forward, as we talk about future uses of telemedicine outside of COVID, I think this would be an area that I think we could make certain advancements and improvements in how we deliver care in our in-center patients, and that we could actually bring in the family members to make it a more comprehensive rounds on our patients. And then obviously, no one knows the fate of this pandemic, how long it's going to be around. Of course, we know there's possibilities of it coming back in the future. So I think this is some form of telemedicine is probably going to be with us even past this COVID epidemic, and that just learning the whole process, learning what works and what doesn't work, etc., I think is very useful for future needs. Next slide. Just quickly, I have some experience with providing care remotely to patients in rural hospitals. Emory has been involved with what we call telenephrology since 2017. And basically, this is for patients who live in rural areas who have their own dialysis clinics. They in South Georgia, that we do not manage these clinics, but the patients go to local hospitals that don't necessarily have an in-center dialysis unit, nor do they have nephrologists that round. And so what typically would happen with the patient if they got sick and presented to this particular hospital, they would have to be transported an hour or longer away to be able to get admitted and be taken care of. So we've been providing remote services for these patients. We have portable dialysis machines where technicians live locally, go in to perform dialysis. I and some of my colleagues oversee these patients. We use FaceTime to see the patients, examine them. We use the electronic stethoscope there, and it works very well. And we can monitor the patient while they're on the dialysis machine. And so this paper here is a poster presentation at the American Society of Nephrology, where we described our experiences with providing dialysis in these patients, and we had excellent outcomes, very low rates of hypotension, etc. So there's a precedent to this remote monitoring of patients while they're on dialysis, and it can work and it can be successful. Next slide. I think this is the last slide, just in summary, that telemedicine is no longer just for rural areas and hospitals, but that we can use it locally, especially in the time of the pandemic. I think it does increase efficiency. And again, as we talked about, hopefully it's something that we can continue in some form in the future. It can certainly now be used in the from a patient's home or any healthcare facility, including the in-center dialysis unit. I have here, it must still be synchronous, and that means it has to be some video capability. It cannot just be by phone or electronic type communication of labs, etc. It needs to include an actual video imaging of the patient. And then I will stop there and look forward to future questions later. Thank you.
Thank you so much, Dr. Lee. Our next speaker is Dr. Irfan Agha. Dr. Agha completed his residency and fellowship training at Washington University in St. Louis. He practices nephrology with a focus on kidney transplantation and is the medical director of the Living Donor Program at the Medical City Dallas Kidney Transplant Center. He's also active in clinical research and heads the research arm of his practice, the Dallas Renal Group. Dr. Agha, thank you for joining us today, and please let me know when you're ready for me to advance your slides.
Thank you. My gratitude to AAKP and for the very kind invitation. This is a very timely webinar, and I thank you for the opportunity to speak to our very dear patients. Many of them seem to be on the call today. So we've had some really outstanding talks focusing on how all of us have had to pivot in real time to continue to take effective care of our patients. And we've talked about how this has affected the care of patients with chronic kidney disease and patients who are on dialysis. And to continue with that theme, we will focus on how we dealt with this epidemic in taking care of our patients who've had kidney transplant or who are going through the process of transplantation during all this. Next slide, please. So unfortunately, patients who've had kidney transplantation seem to be at slightly higher risk because it's intuitive. They're on immunosuppressive medicines. These are medicines that decrease your ability at times to fight certain types of infections. And therefore, if there is a viral infection that were to happen, there would be an increased susceptibility to contract it, and also seems to be the case in many patients that the course may be more severe. And as these patients have to come in for lab draws and clinic visits and so on and so forth, the exposure risk is higher as well. Patients who we may want to go, there we go, thank you. Patients who are getting transplanted during this period of time, we have to worry about certain other facets of concern. The risk of deceased donor kidney derived infection is a little high. What we mean by that is that if the donor of the kidney had COVID infection, then we worry that that infection may travel with the kidney. The risk of high degree of immunosuppression, which happens in the first few months after transplant, obviously predisposes recipients to a higher risk of disease. And also in the case of living donor transplants, we bring in very healthy people who are donating kidneys, and we worry that once we bring them to the hospital milieu, they may actually be at risk for contracting disease, which obviously is a big concern. We're already putting them through a nephrectomy process, taking their kidney out. We thought that it would be in real bad form if we expose them to an infection risk as well. And thirdly, there were logistic issues to consider. We were expecting a fairly big wave and influx of patients. And so, you know, this was one of those situations where the interests of a few trumped the interests of many, and we wanted as much hospital capacity and staff available to focus on these patients who would be coming in with very serious illnesses. Next slide, please. So these were our risk mitigation strategies during this epidemic. Kidney transplantation is a team sport. It is not done in a clinic entirely. We have clinic operations, we have the hospital component, and then we have a very valuable resource, our nurses, technicians, other staff members, as well as our physicians. We didn't want our staff to get sick, because then their ability to deal with this epidemic would obviously be seriously hamstrung. Next slide, please. So in the hospitals, what we did was compartmentalization, which is we created protected renal transplant sanctuaries with identified staff, very strict infection control procedures. We cut out all visitors, et cetera, et cetera. We triaged our transplants, so all non-emergent transplants were delayed, all living donor transplants were essentially canceled. We did some transplants, but these were patients who were difficult to transplant and were getting very good organ offers. So in that scenario, we thought the risk-benefit ratio was assumable. There was a lot of coordination that went into this entire response. This is one of those scenarios where I think the American people have seen how the scientific sausage is made in full public view. Science is never clean, it is never clear, it is always messy initially till the time we go over all the aspects of it, look at all the data, and then eventually settle on a particular doctrine. So I'm sure our audience has been very confused at, okay, should we take hydroxychloroquine? Should we not take hydroxychloroquine? Should we take azithromycin? Should we not take azithromycin? What is remdesivir? What is tocilizumab? And this is something that's been happening in real time. And behind the scenes, transplant institutions, so Medical City Dialysis and HCA institutions, so all the HCA transplant centers have communication portals where we have been discussing these situations in real time. There are ASN portals, there are AST portals where all the transplant physicians have been discussing this to figure out how best to take care of these patients who are coming in with very severe disease. We partnered very closely with our infection control and infectious disease specialists, as well as our pulmonary and critical care teams. And we took very proactive measures as well. So we introduced universal screening of all donors, living or deceased, as well as all recipients. And the plans were to cancel any transplant if one or the other tested positive. Next slide, please. So in the clinic operation scenario, we had to introduce telemedicine straight away. We depend very heavily on frequent lab draws, so that was a big problem. During all this, we did not want to ignore any dangerous tendencies any patient's allograft transplanted organ was showing, so we had to continue to monitor that closely, and we had to still deal with the day-to-day urgent issues that keep coming up once we look at those labs and find abnormalities. So let's see how we did on that. Next slide, please. So telemedicine is intuitively the best solution for this situation. It decreases your exposure risk. Patients like it because you're doing it, in your home. You don't have to sit in a waiting room waiting for the doctor. The patient doesn't come to the doctor, but the doctor goes to the patient. There's peace of mind both for the patient and for us that we have spoken to the patient. The patient looked good. There doesn't seem to be any urgency. And for a lot of issues, telemedicine is extremely effective because we're looking at the laboratories, we're adjusting medicines, we have vital sign data. So 90% of what we need is there. The weak link in all this was lab draws, because if we are calling them into a LabCorp or a Quest or to our clinic lab, then the idea that segregate these patients and keep them out of high-risk environment is defeated prima facie. And so we scratched our heads and tried to figure out how can we avoid exposure of these patients to other patients and to the hospital environment. Next slide, please. And so CareDX had started, you heard at the top of this presentation, the advertisement for RemoTrack. So we partnered with CareDX at our center to introduce RemoTrack. And so the way this works is that after the patient consents, CareDX contacts the patient and sends them the test kit delivery. Then a technician goes into the patient's house, draws blood, and then the results are made available to us. We used other services as well, which we needed to use for short turnarounds. So if a potassium, for instance, was high and we needed a redraw, then we could tap into some of the other services. And there are other home testing services available as well. And these offer broad range. So RemoTrack offers a broad range of tests, including therapeutic drug monitoring, which means we can check your Prograf levels or cyclosporin levels or sirolimus levels, which are immunosuppressive medicines whose levels need to be monitored very, very closely. And also with CareDX, we could get their donor-derived cell-free DNA tested, which is a test we rely on to make sure if the allograft is doing well and that there's no injury to the graft happening. Next slide, please. So from a transplant health surveillance standpoint, this is the whole point where we are doing labs and talking to the patients to make sure that they're doing well. So we could check on telemedicine visits, their clinical state. We could check whether they were taking their medicines or not. A lot of times when patients come to clinic, they forget their medicines at home, but with a telemedicine visit, we are in their home, and so we could say, okay, go grab your medicine box and let's take a look at what you're taking. So that was very helpful. We could look at all the basic labs, we could look at the drug levels, we could look at the cell-free DNAs when applicable and when drawn. So this gave us a very comprehensive look at the patient and the state of function of their kidney. Next slide, please. So now sometimes urgent issues come in. For instance, a high potassium would come in, or a drug level would be up or down, or they would be running out of medicines, or their kidney would be malfunctioning. So we developed protocols to deal with all of those, and I'll give you an example or two of those. Next slide, please. So for things like potassium, we developed a program, and this we brought in our nephrology practice as well, which is actually where this has been used more. So we would have a home draw, and let's suppose a high potassium was resulted. We partnered with several pharmacies in town, depending on the geographic area. So we kind of developed hub pharmacies, and they would act as the hub for a bunch of spokes delivering drug to various patients. Therapy, the pharmacy in an urgent situation had the capability of developing these medicines, delivering these medicines within a 2 to 4 hour window to the patient's house. And so within about 4 to 6 hours after the lab was reported to us, we could initiate therapy at home. And then we had the capability of actually repeating the lab draw at home. So usually for a high potassium-like situation, unless the potassium was dangerously high, in which case they would have to go to the emergency room. But for a moderately high potassium level, we would be able to complete the entire diagnostic and therapeutic cycle with the patient not needing to leave their house and the intervention made. Our transplant patients run high potassiums quite frequently. They're on certain medications that cause the potassium levels to go up. They also sometimes have kidneys that are not functioning at par and have a little difficulty excreting potassium. So this is a common scenario for which we have to call patients to the emergency room, and by deploying mechanisms like this, we were able to decrease emergency room referrals and treat them at home. Next slide, please. So with this rapid pivot to telemedicine and home blood draws, we were able to take care of our patients effectively and more than 90% of the visits in the past month or so have been done on a telemedicine platform. Our staff attrition rates have been negligible. We really have not had any staff that have been diagnosed with the infection themselves. We have had no physician attrition. All of our physicians are up and running. A few of our transplant patients did develop the infection. All have recovered except one still in the hospital, but expected to make a complete recovery. We did few transplants during this period of time, but grace of God, all of them have done well. And so we have worked hard to protect our patients during this epidemic, and so far things have gone well for our transplant patients. So I will stop here, and we'll probably wait for the questions till the end, right?
Yes. Thank you so much, Dr. Agha. Our next two speakers are kidney patients who will share with you their experiences with telemedicine. First up, we have Patrick G. Patrick is a former peritoneal dialysis patient and a 2.5-year kidney transplant recipient. He affectionately named his kidney Lazarus. As a healthcare consultant and consumer advocate, he is very passionate about advocating on behalf of the underserved, undervalued, disenfranchised communities of fellow kidney patients. Patrick's advocacy focus is for a more comprehensive and universal health care, effective and realistic patient engagement, health educational toolkits being dispensed in low-income communities, social, moral, and ethical injustices and perspectives concerning genetic differences in research, and a better quality of life for kidney patients. Patrick's motto is, I am the voice for the voiceless and the face of the faceless in the fight against kidney disease. Patrick is a patient subject matter expert, co-chair of the Network Patient Advisory Committee, an AAKP ambassador, and he also serves on AAKP's board of directors. Patrick, thank you so much for joining us today.
Thank you, Erin, and I want to take this time to thank the leadership at AAKP as well as Network 5 just for this opportunity to, share my brief experience with telemedicine. I was first introduced to telemedicine and telehealth in 2013 when I first began dialysis. Right before I did dialysis, George Washington University was conducting a study, a clinical research trial on telehealth. So at that time, we received an electronic weight scale, an electronic home blood pressure monitor, as well as a webcam to hook up to your laptop. It was exciting, but it was never implemented. For what reason, I don't know why, but it was just kind of a sully experience that I couldn't understand that. But here we go to the COVID environment right now, and this is where I experienced telehealth for the first time. In March of this year, I was COVID positive. My wife was also diagnosed being COVID positive. And one of the things that I learned in being that my transplant care team actually jumped into action ahead of time. I was afforded to be able to communicate virtually with all of my physicians, my primary care physician, my weight loss nutritionalist, and my transplant nephrologist and care team. When I was diagnosed with being positive with COVID, of course, the maintenance part of my recovery took place. They administered medication. I was also scheduled to utilize CareDX RemoTrack, but because I was positive, they had to put that to the side. As I began to recover initially from the first set of symptoms that I had experienced, I started developing secondary symptoms, which were more severe. And it is believed to have been from the side effects of the hydroxychloroquine that I was prescribed. So in a virtual check-in with my nephrology team, I was able to share the secondary symptoms that I had. And it was at that time where my nephrologist told me, just go ahead and pack a bag. And they were going to admit me to the hospital for an evaluation and a series of tests. So I went to the hospital. I retested for COVID, and I was negative. Since then, all of my appointments have been virtually. I have left the house twice. That was to go to a secure offsite unit to do labs. And I actually had to go back to my center because my center wanted to do antibody checks. So the new normal, as folks want to talk about, when I went back to the hospital was very interesting, and where as soon as I stepped into the building, I was checked, of course, for my temperature. I had to sign a waiver. I had to go to the front desk area to receive an armband and to make sure that they had me listed for actually having an appointment. And I even had security to escort me to the center where I had my blood labs drawn, and then to escort me back out. So I'm not sure if that's going to be the new norm for now, but I know that precautionary measures are in place. One of the things that I really liked about telehealth is that through various apps, such as I'm a diabetic, so I'm able to send my my glucose levels as well as the foods that I eat to my nutritionalist prior to any virtual appointment that I have with them. For my nephrology team, I'm able to also send in those same labs, as well as also being able to send in a questionnaire of my weight, my blood pressures, and all of these pertinent things, any ailments, any medication changes to my team prior to my virtual check-in. So for me, my telehealth experience has been very beneficial, and I just thank God that I have a very updated patient-centered transplant care team that's on, that is utilizing on the edge modern technology. So for the patients that are out there listening to this, I would really advise you to educate yourself on what you receive from this webinar. Talk to your care team, as well as any care partners, caregivers, or support systems that you have in place, and see if the availability for everything that was talked about today can be offered to you. Thank you, Erin.
Thank you so much, Patrick. Our next speaker is Dawn Edwards. Dawn is a self-described 28-year chronic kidney disease savage. She has experienced firsthand every renal replacement modality, including a kidney transplant and rejection. As a result, she has a plethora of insight into the needs of people with CKD, always keeping in mind that patients need different things at different times in their lives. Dawn is dedicated to improving the quality of life of people with kidney disease, and is also a resource to her community sharing her story and educating people about the relationship between hypertension, diabetes, and kidney disease, especially among people of color. Dawn has served the community for over 20 years through the iPro ESRD network of New York as a communicator, mentor, and educator. She serves on many kidney disease-related boards and has reinvented herself by working as a patient advocate for NextStage, the Wellness Ambassador for the Rogetson Institute, AAKP Ambassador, and is the CEO of her own advocacy and education organization, the New York State CKD Champions, whose motto is to educate, encourage, and empower. She believes that faith, family, and education are the keys to her longevity, and every day is an opportunity to thrive, not just survive. Dawn, thank you so much for joining us today.
Good afternoon, everyone. Thank you so much for the opportunity to be with you this afternoon. These certainly are challenging times, and I'm really thankful to the AAKP for providing this platform for us to share information with patients, and I surely hope that everyone gets a little something to take along with them to help your journey to be a little bit easier. I also want to say happy birthday to Diana Kleins today. Today is her birthday. She's our leader of the AAKP, so happy birthday to you, Diana. And I also want to say a little thank you before I get started to our Centers for Medicare Services, Health and Human Services, the National Kidney Foundation, the AAKP, and Home Dialyzers United for advocating for home dialysis patients for our special needs during this crucial time. So yes, you can go ahead and advance the slides, and I'm going to talk really quickly. So just to begin, telehealth has really provided a real added convenience and security among home dialysis patients. We're used to monthly having to pack ourselves up and get out there and go to the dialysis clinics to see our nurses. Our PD patients have to go twice a month. Home hemodialysis patients like myself go once a month. A lot of us are actually in the dialysis clinics where we go for our clinic visits. And that can lead to, a couple of issues when we're talking about pandemic and infection control. So telehealth has really been a great resource for us during this time. I know that I am a patient at a large dialysis organization, and my team has been absolutely phenomenal with being concerned about my care and being concerned about my safety during this pandemic time. Some of the benefits of telehealth, is that the patient can use their own device, whatever smart device they have at home, and it eliminates unnecessary travel, which is a wonderful thing. A lot of our patients are rural. They live some distance from their dialysis center, and you get to have your visit with your care team right in the comfort of your own home. And that helps us to limit exposure. We're supposed to be sheltered in a lot of areas. I'm from New York City, which is the epicenter of the pandemic, and it has really been challenging. And we've been sheltering in since March. So going out to a clinic visit really could be a source of contamination for us, especially in dialysis centers where they're treating COVID positive patients, and they're also, exposed to other sources of contamination as well. So telehealth it greatly reduces our risk for contamination. It also gives us a great opportunity to dialogue with the entire care team at once. What I really like about that is that your dietitian, your social worker, your physician, and your nurse can all be in your telehealth session all at once, and everybody can talk to you just like when you go to your clinic visit. And that's really helpful to me because I like to speak to every member of my care team when I do go to my clinic visit. I want to get as much out of those visits as possible. It also saves money and time. I haven't filled up my gas tank in quite some time, so I'm really liking that. And that's a really good benefit of using the telehealth. And I know a lot of people, some people drive many miles to get to their dialysis center. So telehealth can definitely save you a couple of pennies. And the CARES Act that was recently instituted, the waiver section 3705 has afforded even greater benefits for our home patients. Dialysis in and of itself is kind of a niche area of healthcare, but the home dialysis is even a niche within a niche. So we just want to thank all of those who advocated for home dialysis patients to get this waiver section 3705 passed and instituted for our home dialysis patients. Because before that waiver section 3705, face-to-face clinic visits were required every 3 months. You could have the telehealth visits for 2 months, but on that third month, you had to have the face-to-face visit. So what's great about that is the waiver section 3705 has done away with that every 3 months face-to-face visit until further notice. So this is exactly the verbiage of the section 3705 in the CARES Act. And you can see clearly that there was a temporary waiver of the requirement for face-to-face visits between home dialysis patients and physicians. That's the actual verbiage. And so what this means is that the provisions in the CARES Act was that face-to-face visits for home dialysis patients were to be conducted via telehealth until further notice. In other words, the rule is that was that you had to have that every 3 months face-to-face visit, but that has been suspended by federal legislation, and that's been causing a little bit of confusion throughout the home dialysis community. Next slide, please. Interpretation of that section 3705 that I just talked about seems to have been causing some issue among certain dialysis providers or certain dialysis centers or with patients on the whole. And we want to try to hopefully educate our hearers, and we want to let patients know exactly what 3705 means to them and what it is that we can be asking for. Most providers, of course, have complied. My facility's doing great with it, and they have patients using apps. They have some facilities, some providers have their own apps. I know that there's Next to Me, there's Care Connect, and then some other providers are using Zoom for their telehealth meetings. Of course, PD patients have to go in monthly for those monthly blood draws, but that clinic visit can be done via telehealth, and we have to ask for that if they're not offered to us. According to the section 3705, home patients should be ordered telehealth. That is provided that the patient's in stable condition. Now, if you're not doing well, if you have some exit site issues, or if you have some reason that you need a physical assessment, your care team may require you to come into the facility for a clinical visit. So don't be surprised if, due to your lab results or what have you, you may be required to come in for a physical assessment. Now, but if you would like to have a face-to-face visit, you should absolutely do so. Even if you are in stable condition and you just want to see your care team, you absolutely have the right to do that. But our facilities should not be forcing patients to come in. If you do not feel safe, you don't feel comfortable, the telehealth visit is absolutely our right, and it should be offered to us. There's no issue as far as payment is concerned. The facilities are going to get paid whether we do a telehealth visit or we do a face-to-face visit, and that's the whole reason for the ruling in the first place. It's for our home patients' convenience and safety. So in some cases, it also covers the self-administration of some medications. Some patients go in just for an EPO shot, and you can ask your facility to teach you how to administer your own Epogen or other medications if you're capable. So that's something that during this sheltering in period, if you have to go in for medications, you can ask them if they would be able to train you to administer some of your own medications to save you a trip out. If you are having problems with getting your telehealth visits and your facility is not complying with Section 3705 and you're not satisfied with the answers or the results that you're getting after trying to discuss your desires with your facility, you're always at liberty to contact your ESRD network. You should not be forced to come in for a visit, and telehealth should be offered to you. And if it is not offered or it's not a consideration, there is a platform for you to express your complaints or concerns. So everyone should know about your ESRD network, and that's who you contact for your complaints or your grievances. Next slide, please. Telehealth has been really a blessing for me. I've been able to see several of my healthcare providers through telehealth, and I just wanted to share a couple of tips with everyone. If you haven't had your telehealth visit yet and you have one coming up, there's a couple of things to remember so that you can have a successful visit and get the most out of your appointment. The first thing is to make sure you download that app, whatever it is the platform is, on your smart device. You download it before the appointment so you are not having technical issues on the day of your appointment. And I would always suggest to play around with it once you download it to kind of learn the features. You click on this, push that. Every platform is different. I know that I use so many platforms now during this time. Everybody has a different app that they use for meetings and what have you. So you have to play around with those and kind of learn how it works. I would definitely talk to my home nurse before the actual appointment to find out who will be at this meeting. Is it my entire interdisciplinary team, which would be the ideal scenario? However, we know that that's not always possible. It would be great if you could have your nurse, your physician, your social worker, and the dietitian. But it's good to find out in advance who's going to be there at that visit so that you can be properly prepared for that. Another thing is to always, walk around the house, choose a comfortable location, someplace that you know that's going to be nice and quiet so that you can hear and so that you can be heard by your team, and someplace that you feel comfortable talking about your health conditions and your specific issues that is secure. You definitely wouldn't. You may not want to be in a room where people are coming in and out the door and they may be able to hear your private health issues being discussed. And another one of my tips is, I know in my house, there's certain rooms where I have better Wi-Fi than others. So you want to pick the room that has the best Wi-Fi as well, so that you don't get your visit interrupted while you're discussing your important information. And if you don't have good Wi-Fi in your house, or you don't have a smart device, or you have some type of any type of techno issues, you want to definitely discuss that with your nurse beforehand, because you can always request a telephone visit. The good old telephone still works. You can talk to your care team via telephone if you have some technological issues. And you want to make sure that you sign in early. It's always good to give yourself a few minutes. If your appointment is at 2:15, you maybe want to sign in at 2 o'clock to make sure that you're logged in and you're on the right platform and you know which buttons to push so that you're not like me and not unmute yourself at the appropriate time. And any technical issues you can deal with before the actual appointment, because we know our physicians are on a time schedule and we want to get the most out of that appointment. Another thing is to get dressed. If it's going to be a video meeting, you wouldn't want to really show up in your pajamas, or you may be embarrassed about your hair. I know I haven't had my hair done in quite some time, but we try to get it together. And at least from the waist up, you can get dressed for your meeting. And the most important thing is to think about things that you've experienced during the course of the month, any questions or concerns that you may have. Write them down, because once you get into the meeting, it's going to go quickly and you don't want to forget any of those important questions or concerns that you want to address with your care team. Next slide, please. So there's some things that you don't want to forget to ask when you go to have your clinic visit. This is just like when you go and see your doctor at the clinic. You want to know how your lab results are. What's my blood work? What's going on? How did everything look? Of course, they're going to talk to you about that anyway. But if you have any specific questions, you want to ask those. You want to know if there's any changes to your medications, or should you still be taking your medications the same way as a result of those lab work results. Remember about your refills. That's one of the things that I forget sometimes. I say, oh, gee, I forgot to, tell the doctor about I need a refill on so-and-so. And then you can't get in touch with them because they're so busy. So you want to make sure you check your medications before your visit and write that down if you need any refills, so that you can tell them while you're on your meeting call, in your meeting session. And if your dietitian's available, or any other members of your care team, you want to find out if there's any necessary dietary changes that you need to address, any social services or needs. I know during this time, some people need meals delivered, or they may need help with obtaining a smart device. And these are things that you could talk to your social worker about while you're on your appointment or while you're having your clinic visit. And also, you want to make sure you have that inventory of your supplies. There's a shortage on supplies. Sometimes we're having trouble with deliveries, and during your clinic visit, that's the time to let your nurse know that, whatever it is that you need, because you don't know if you'll have a chance to be able to get a hold of them later on. So that's just some of the things that I think are really important, how we can really use telehealth to be beneficial to us. It keeps us safe. It helps us to stay indoors and really limits our risk of exposure and possible contamination. So I hope that everyone, got a little something out of that, and you continue to take care of yourself. Home dialysis is really a benefit now, more than ever. And I hope everyone stays safe and stays healthy. Thank you so much.
Thank you so much, Dawn, and thank you to all of today's speakers. This is a really comprehensive webinar. We received a couple of questions during the presentation that were definitely addressed. If you do have a question that was not answered during the webinar, please email us at info@aakp.org, and we'll work with our speakers to provide a response. We have just a few closing slides here. If you're not a member of AAKP, we encourage you to join us. We offer free membership to patients and family members, as well as living kidney donors. You can join online at aakp.org or by phone at 800-749-2257. Please be sure to include your email address when signing up so you can receive all of our membership benefits. You will be notified by email when opportunities arise where your opinions and experiences are needed to help inform innovation, advance care, and make a meaningful impact to improve lives. We also encourage you to respond to our flash surveys and other engagement opportunities to help us elevate the patient voice and change the status quo of kidney disease care. You can also select to receive any of our 5 different electronic newsletters and subscribe to our printed bi-monthly magazine, AAKP Renal Life. We also invite you to follow us on social media for all the latest news and announcements. AAKP is dedicated to helping patients understand their condition and take control of their health care. We are proud to offer a variety of resources for both patients, family members, and caregivers. By visiting our website and clicking on the AAKP store button at the top of the homepage, you can find a variety of educational brochures and online tools to order online, by phone, or download. We hold a number of events throughout the year, and these events are live streamed and recorded. Please visit our YouTube channel to watch presentations from our Global Summit on Kidney Innovation, hosted in partnership with George Washington University, our annual Policy Summit, and our annual National Patient Meeting. I'd like to remind everyone that this webinar has been recorded and will be made available on our coronavirus resource page. For more patient resources on COVID-19 and to listen on demand to today's webinars or any of the previous webinars we have hosted with our strategic partners like the Center for Disease Control and Prevention, please visit the coronavirus resource page on the AAKP website. You'll see a big red coronavirus information button on our homepage, www.aakp.org. We'd again like to thank today's speakers for sharing with us important information. And if you have a question that we did not get to during today's webinar, please reach out to us at info@aakp.org. And again, we would like to thank CareDX for sponsoring today's webinar. Thank you all so much for joining us. Be informed and stay safe.